right here at Teachers College, Columbia. He's an associate professor and director of doctoral training for both the education psychology and counseling psychology programs at the University of Albany. Dr. Pieterse conducts research on health-related outcomes associated with the experience of racism, anti-racism advocacy, race-related aspects of counseling psychology training, and the impact of self-awareness on the psychotherapy process. Thank you so much for joining us. We're delighted to have you here today. Frequently, I get questions from trainees and from supervisors about how best to talk about race in the supervision, and sometimes fears and anxieties and worries about not being able to do it right or well. So really looking forward to what you might have to tell us and today.
Thanks so much for the introduction and for the invitation. I'm really delighted to be spending some time not only just now, but listening to the other presenters as well. Really important topics, and appreciate you opening up space to address these really important topics. So thank you very much. I'm going to share my screen, and hopefully that will give everyone access to my slides. Okay, so we can see those?
Yes.
Great. So again, I'm delighted to be spending some time with all of you, thinking collectively about how we can perhaps do a more effective job at attending to race in clinical supervision, and appreciate, again, being able to speak with you. I'm planning to speak for about 15 minutes. I hope. I am verbose, so I'll do my best to manage my verbosity. And then I'm really interested in some dialogue and discussion, or hearing thoughts, questions about how we can, collectively attend to race in a more effective manner. So it's important for me, as I start, just to acknowledge with you, and also to remind you that my cultural tradition, I am originally from South Africa, reminds us that a person is a person because of other persons. And it's always important to me, when I have a chance to present, to acknowledge people who have come before me that have really paved the way for me. My mentors, Robert Carter, who up until recently was at Teachers College, Lisa Suzuki, who's at NYU. These are people who have shaped my life tremendously. And then, students, graduate students I work with every day, clients that I work with in therapy, certainly my family and my sons. I have 3 sons. They take great delight in telling me that I'm not as smart as I think I am. And sometimes that's a good message to hear. So, just to acknowledge that there are folk in my life that have and continue to play a really important role in shaping who I am, both personally and professionally. Also important for me just to share with you my identities. The topic that we are going to be discussing this afternoon, for me, is inherently a very personal topic, given my racialized background. So I think it's important just for you. You've already been introduced to some of my professional identities, but certainly the personal identities that shape my work are equally, possibly more important than the professional identities. So I identify as Black. I'm a cisgender heterosexual male. I am a father to 3 young Black men, which carries salience in the racialized society that we live in. There are other aspects of who I am in regard to family. I'm a partner, a son, a brother. I'm also an immigrant to this great country. I'm an immigrant to the United States, to the state of New York, and have been living in Albany, New York, for the past 10 years or so. And prior to that, lived in New York City for many years. So again, I think these identities really shape, how I approach my work as an academic, as a scholar. They inform my teaching, and I also believe they inform my clinical work. And so again, the nature of what we do in mental health and other aspects of the helping profession, I think, dictates that who we are our personal subjectivities are critical aspects of how we go about our work. Over the past year, my identity as a father, and especially a father to 3 young Black men, has carried more salience, as we've witnessed really unfortunate aspects of police brutality, and how I've had to engage those discussions with my sons. And so that clearly is an identity that carries much salience at the moment. So I think it's important, and I would invite you, in a personal reflection, just to pause and think about what aspect of your personal identity is salient for you today, in this space. We've just had a wonderful presentation from Dr. Ackerman Berger, thinking about what microaggressions are, how to confront, how to manage. And so again, how did your personal identity shape how you engaged the material that she was sharing? What did you hear? What did you not hear? Who did you see represented in some of the illustrations she was sharing with us? Who did you not see? And how did you feel? What did you feel? What did you not feel? I think all of these are really critical reminders of how our identity shapes how we engage space. And so I would invite you, as we are sharing some time together now and with the speaker that's to follow, just to be attentive. If you have a reaction, if you have a thought, to be attentive to how your identity might be shaping some of that space. So why are we in 2021 still needing to have discussions about race, racial difference, racial microaggressions, individual and structural racism, all aspects that inform and shape the work we do as mental health professionals? I think like many of you, I was encouraged when earlier this year, the American Psychiatric Association outlined an apology. I really experienced it as perhaps the beginning of accountability, and hopefully a movement towards accountability that will move way beyond this apology. But again, I wanted to just acknowledge this apology with you. And some of it relates to some of the comments that will follow. So the piece that I'm pulling from the apology, and I've listed the website if you want to have a read of the entire statement, it's there for you to access. The piece I'm sharing is them stating that since the APA's inception, practitioners have at times subjected persons of African descent and Indigenous people who suffered from mental illness to abusive treatment, experimentation, victimization in the name of scientific evidence, along with racialized theories that attempted to confirm their deficit status. And our previous speaker already alluded to some of these racialized theories that have been part of the unfortunate history of mental health and healthcare in general. The APA statement continues to state these appalling past actions, as well as their harmful effects, are ingrained in the structure of psychiatric practice and continue to harm Black individuals, Indigenous folk, other people of color, our psychological well-being, even to today. So why are we talking about race, racial difference, racial microaggressions, the need for humility in our practice? Partly because of the history of how psychiatry, psychology has handled racial difference and how those effects continue to impact us to this day. So I have got a fairly ambitious overview of what I would like to share with you. I want us to very briefly, just reflect on how we've dealt with difference in our field, conceptual approaches that have informed the field. Then I want to more broadly think about racial difference within supervision and share with you an illustration from my own practice as a supervisor. Then I'd like to more narrowly attend to racial trauma as an aspect of racism and how that might play out in clinical supervision, and then share some brief comments on intervention and prevention of racial trauma. And hopefully if I can do that in a timely fashion, we will have plenty of time to engage some reflection and discussion. So I've got a poll. I'm feeling a little nervous because I've never done this polling before. So if Hillary's on the line, she might need to help me here. But I have 4 questions that I would like us to engage as a poll. 2 questions now and 2 questions a little later in the presentation. So let me, okay. So here is the first question. In my role as supervisor, I feel comfortable addressing interpersonal dynamics between a supervisee and myself. So I'm just asking you to respond to that using this little Likert scale that we have here. And let me launch the poll. So in my role as a supervisor, I feel comfortable addressing interpersonal dynamics between a supervisee and myself. Okay. So like a good researcher, I'm waiting for a good enough N that can inform our understanding of the responses. Okay, so we have 65% response rate. So let's end the poll because there are additional questions to follow. Okay. And let's look at the results. Okay, so here we have, in response to interpersonal dynamics, we have 47% who have agreed with that statement and 12% who have strongly agreed. So clearly, the majority of you feel comfortable attending to interpersonal dynamics between yourself and your supervisee. Okay. So now let me get to the next polling question. So here we go. Here's the second one. In my role as a supervisor, I feel comfortable addressing racial dynamics between a supervisee and myself. Okay. So the first was about interpersonal dynamics. The second is more specifically about racial dynamics between a supervisee and myself as a supervisor. Let me launch the poll and let's see what type of responses we get here. Okay, so we've got about 70% of responses. Let's end the poll and look at the results, okay? So here we have a similar pattern, although it's a little lower in regard to both the agree and the strongly agree. So we have about 47% of folk who are feeling relatively comfortable addressing racial dynamics. And then we have 28, 29, okay, so close to 45, 50% of folk who are not sure or who disagree. Okay, so it seems like the confidence in addressing racial dynamics are perhaps a little lower than the confidence in just attending to interpersonal dynamics. Okay? And so thanks for engaging that. We'll come back and later on have a couple of other questions that speak to engaging racial trauma. So that poll gives you a sense of, you know, there's less confidence in attending to racial difference. And I'm hoping that some of the comments that we share will give you perhaps a framework or stimulate some thinking about how you could perhaps grow your confidence or your willingness to address racial difference within supervision. I am, oh, that came back up there. I am drawing from a fairly wide body of literature. Again, I'm sure I'll be able to share these slides, so you'll be able to peruse this literature on your own. But there has, especially over the past couple of decades, I think been some really important and useful writing about race and supervision from various perspectives, from psychodynamic perspectives as well. So this is some of the literature that I am drawing from as we engage our discussion this afternoon. So let me frame the discussion in the context of outlining race and racism. Okay? Clearly, race is a significant factor in our society. And Hardy references race, Kenneth Hardy is a family therapist, references race as a major organizing principle in everyday life. And so indicates that the social reality of race and racism has a huge influence on the lives and relationships of all of us. So I think this is a nice reminder that irrespective of your racial background, given the way that we do race in our society and how race is kind of an organizing principle, irrespective of your racial background, race has an influence in your life and how you negotiate relationships. And so that comes directly into thinking about the experience of supervision. Eklund reminds us that racial match as an aspect of supervision is important to consider because it has impacts for both the therapeutic endeavor, but also the clinical endeavor. So what takes place between the supervisor and the trainee might well have an impact on what takes place between the trainee and their client or their patient. Okay, so really important that we think of how racial difference or how we attend to racial difference and racial dynamics might have an impact clinically as well. So I am going to perhaps share with you at the beginning of my presentation what I think is what I would like to be the most important piece of the presentation that you can keep with you. Dealing with racial difference. So I think as therapists, as clinicians, we have a really useful model for attending to racial difference in the context of how we attend to dynamics of resistance in psychotherapy. Okay? So those of you who are supervisors or who have done some instruction in psychotherapy or counseling, I think you'll appreciate the dynamic the perspective that I'll share with you. Often when novice therapists are starting their work as a therapist or as a counselor, in my experience as an instructor and supervisor, what they really want from us is, what do I do? How do I do it? What do I say? When do I say it? And if the clients are struggling in the process, it's not uncommon for them to label the client's experience as resistant. And what I have tried to share with both supervisors and students in my perspective is that resistance is never something that we should view as an adversary in the process. It's not something that we should view as needing to be overcome. Okay. Instead, experienced clinicians, I think, appreciate resistance as something that first and foremost needs to be understood, needs to be respected, and really needs to be embraced in the work. Okay? And so I am inviting you to take that same model and apply it to thinking about racial difference in the therapeutic setting. Okay? I'm asking you not to think about racial difference as a problem, view it as problematic. Instead, oh, excuse me. Excuse me. Instead, I'm asking you to think about it as an opportunity, and specifically as an opportunity for deeper understanding and a more effective, a deeper working alliance. So just as you might facilitate, process dynamics of resistance, bring that within the work, I'm asking you to think about your processing, facilitating, accepting racial difference as an important opportunity in therapeutic work. Okay, so if you forget everything else I say this afternoon, which I'm hoping you won't, but you might well, I'm asking you to kind of think about how to appreciate racial difference as an opportunity for deeper understanding, a more effective working alliance. So the history of psychiatry and psychology, I think, has various conceptual approaches that we've utilized over the years, which some are incredibly problematic and some offer more promise. Okay? So our previous speaker referenced some of the racialized theories that speak to notions of inferiority, and reference the eugenics movement. So, most probably the American contribution of psychology has been most prominent in the area of psychological assessment. Okay. And certainly IQ testing has got a long history in our field. And really the foundations, or the starting of IQ testing in the United States was really problematic in regard to notions of biological inferiority. So Terman, writing in 1919, really identified various racial groups in the United States as being, as exhibiting inferior intellect, and really referenced that as part of their biology. So we disavow that. We've moved away from that. We recognize that paradigms of inferiority are not a useful way of understanding difference. Around the civil rights era just before then, we had some psychologists, psychiatrists who really, while moving away from positions of biological inferiority, adopted this kind of social deprivation paradigm. And some of the work came right out of New York City, also made its way into the political arena. And it really viewed behavioral deficits, personality deficits within certain racial groups as being a function of social disadvantage. Okay? But that's still placing a kind of overly negative take on the psychological experiences of some racial groups. And then more recently, we've moved to the cultural difference paradigm. So we've disavowing deficit models, and we just appreciating that, difference is just difference. And so the multicultural movement, I think, has been really influential in that process. Some of the work of Gerald Wing-Sue, some of the work he's done around racial and ethnic identity, Janet Helms, Robert Carter, the folk have done work on ethnic identity, has really helped us appreciate that there's a lot of heterogeneity that exists within racial groups. And so I think to some degree, that's where we are at the moment. We're appreciating difference just as difference, and we're trying not to overlay our understanding of difference with paradigms of inferiority. But still there is there's some residue that I think remains based on earlier paradigms that were both very influential and very, I think, damaging in our field. And I think within the conceptualization of racial difference, I think we also have to appreciate that given the racial hierarchy that exists within our society, difference is also associated with social location. Okay? So if you think of difference in the context of social stratification, you recognize that social stratification is associated with privilege and oppression. And then we have various socialization processes that really inform how we maintain a kind of disequal dynamic in our society. So I referenced some of my own identities as I started my discussion. In some of my personal identities, I'm a Black male. I identify as heterosexual. So even within my identities, I carry identities that are both oppressed in some context, race, and privileged in some contexts in regard to heterosexual identities and gender. So again, it's important to understand that difference also carries with it notions of privilege, oppression, dominance, subordination within our society. So as physical and social scientists, we appreciate that race is no longer considered to be a biological attribute. Okay? Given the utility of genetics and how that has informed our understanding of difference, I think we've viewed away from race as being viewed as a kind of biological construct, but we still appreciate that race is a social construct, okay? A socio-political construct, I would argue. And in that regard, I think Marta from University of Chicago really reminds us that irrespective of our understanding of race as not a biological construct, as a social construct, it still carries enormous weight in our society. And so people will behave based on their assumption about what racial traits or racial difference actually means. And I think some of that seeps its way right into the consulting room, both in regard to the supervisor and the supervisee. Okay. We cannot talk about race without talking about racism, because in many ways, race in our society is in the service of racism. You know, we would not have racism if it weren't for racial categorization. And so in my work, I use a widely appreciated definition of racism, which simply states that racism is a construct that combines an ideological aspect, so the ideology of racial superiority, and a behavioral aspect, which is discrimination, prejudice, and the behavioral aspect is some of the microaggressions that we were hearing about in the earlier discussion. So race and racism is really a core aspect of our society. And Miller and Goran in this really useful, if you're not familiar with this volume, it's a very useful volume for those of us in the helping professions, irrespective of what profession we are in. Miller and Goran kind of presented diagrammatically this, what they call this web of institutional racism. Okay? Just reminding us that racism as a kind of institutional systemic construct really gets into all aspects of social construction in our society. And so if we want to be effective at kind of countering that, we need to appreciate how it plays out in our society. And I think we also need to appreciate the racial structure. And when we're talking about race, particularly racism, the racial structure in the United States continues to give primacy to the construct of whiteness. Okay? In my work, I really draw heavily on Ruth Frankenberg's definition, discussion of whiteness, which was published a while back now. But if you think of what we've experienced in our country over the past 4 to 6 years, I think this definition has a really kind of urgent relevance. So Frankenberg identified whiteness as a dominant cultural space that carried political significance, and the goal of whiteness is to keep others on the margin. Okay? So white culture is viewed as the dominant culture, which in a sense sets the standard, sets the norm, and everybody else is then compared to that norm. And almost with kind of prophetic relevance, Frankenberg, writing in 1993, states that in times of perceived threat, the normative group may well attempt to reassert its normativity. And I think that's part of what we've seen over the past few years, be it, reasserting kind of physical space, building walls to keep people out, reasserting notions of white supremacy. And clearly, our field, psychiatry and psychology, has its own history associated with how we've kind of viewed whiteness as normative. So in order to appreciate how racial dynamics play out in supervision, I think it's really critical to kind of hold on to the overarching structure of race in our society, racial categorization, how that's associated with racism, and how the overarching construct of whiteness is really what we're struggling with when we think of deconstructing some of our racial structure in our country. So as I mentioned previously, race has received some attention in the supervision literature. And some of the areas in which race has been addressed is in the context of racial similarity, dissimilarity, racial microaggressions, the role of racial identity, and more recently, the role of racial trauma, which is the piece that I'm going to speak to in a little while. Okay? So these are some of the kind of frameworks in which we've tried to understand how race plays out within supervision. We cannot talk about supervision without at least providing a definition of clinical supervision. The definition that I utilize is by Watkins. And Watkins describes psychotherapy supervision, clinical supervision, as a dynamic which usually involves a senior professional providing relationship-based, treatment-focused education and training. Okay? So it's a relational endeavor that is focused on treatment and facilitates education and training of junior colleagues. Clearly, as does the psychotherapy literature, the supervisory or the supervision literature also indicates the effect of the supervisory relationship. We call it the working alliance, the supervision alliance. But the supervision alliance has been noted to be perhaps one of the most critical aspects of effective supervision. And in that sense, Watkins says it's increasingly being granted primacy when you think about supervision relationships or the process of doing supervision. And then also recently, we've come to appreciate culture and how culture informs supervision as well, just as we've increasingly appreciated how culture informs psychotherapy. And again, I'm using culture from a very, very broad perspective. So let me share with you an illustration that I'll come back to as we go through our discussion as a way of just kind of stimulating your thoughts around racial difference within psychotherapy, within clinical supervision. So the illustration that I'm sharing with you is one that I was personally involved in. I was the supervisor. And let me just give you a kind of brief context. The setting of the supervision was at our psychology clinic. We've got a psychology training clinic in Albany, New York that we share with the clinical PhD and the counseling PhD program. My supervisee was a white female in the second year of her program, and really was an individual who was very focused on understanding herself as a cultural being, was attentive to multicultural aspects of psychotherapy, and had a certain level of racial consciousness, which becomes important as I share what transpired. The supervisor was myself, a Black male. I was an assistant professor at that time and a licensed psychologist. And the client was a young African-American female. Some important demographic markers was this was a 19-year-old young woman, came from a lower socioeconomic status, had two young children. She was a 19-year-old, had I believe a 3-year-old and a 9-month-old. And the father of her children was currently incarcerated at the time. So the supervisee, to my surprise, 2 to 3 sessions in both into the clinical work and into our supervision, the supervisee had not engaged either with the client or with me a kind of thoughtful discussion about the client's racial background and how that might be impacting the work, which was surprising to me because this was an individual that I perceived typically as being quite aware around race and culture. So in the supervision focus, this was early on in the work, we were focused on building the therapeutic alliance I experienced my supervisee as being very tentative and cautious in their interaction with their client. And as a result, I experienced my supervisee as kind of less genuine in the interactions and clearly different from how I perceived her working with other clients. As we started to process what was going on, the supervisee disclosed to me that she had a perception that she was going to be or was being evaluated from the perspective of race. So she had this heightened kind of attentiveness to the fact that she was a white therapist working with a Black individual, and she was, concerned about how I would be evaluating her. And as I mentioned, the client the supervisor had not really engaged the client's race, and she disclosed to me in the process that part of what interfered with her ability to engage the client racially was her sense that the young woman she was working with filled many kind of stereotypical notions of what it means to be a young Black woman coming from a lower SES background, a single mom, a partner was incarcerated, etc. And so she disclosed to me that she was scared, not scared, that's a strong word. She was concerned about raising the client's racial experience because of not wanting to be perceived as engaging with the client based on racial stereotypes. Okay, so that's, I think, I think it's actually a nice and common illustration of how our supervisees sometimes struggle with how to engage racial difference within a therapy process. So I'll come back to that in a second, but let me share with you, some information that you can glean from the supervision literature in regard to racial dynamics. There was a wonderful issue that was published in 2019 in TEPP, that's Training and Education in Professional Psychology. It's an American Psychological Association journal. And then there was some research done by Alan Burkhardt, who was at Marquette. And I'm drawing from two studies that he and his colleagues published in 2006 and another in 2014. And they just outline some dynamics that occur, especially in the context of cross-racial supervision dyads or supervisory processes. So supervisee of color. So supervisors of color have reported experiencing racial microaggressions in supervision. And again, I appreciate the earlier discussion on what racial microaggressions are. They've also reported supervisors not addressing racial or cultural difference. And in the process, they have responded by reporting feeling shut down, feeling more vigilant, being on guard, being less willing to authentically engage, and being less disclosing. So quickly you can appreciate that if you have a supervisor that is less trusting of their supervisor or less disclosing, that's going to have both an impact on the supervisory process, but might have an impact on the clinical work as well. Supervisors of color also report that when working with a supervisor who acknowledges racial difference, they experience a stronger therapeutic bond. They perceive improved clinical outcomes, and they report this experience of safety. Okay. In some of the literature, white supervisors disclose expecting, when working with a supervisee of color, I got my little guides mixed up here. White supervisees report expecting cultural competence when working with supervisors of color, more so than when working with white supervisors. White supervisors have also reported feeling discomfort when challenged around issues of race, also experiencing opportunities for growth as a clinician when their supervisor addresses racial difference, and also reporting a stronger working alliance when racial considerations are broached. So supervisors of color supervisors of color in the literature have reported experiencing overt discrimination from white supervisees. And some of this discrimination takes the form of having their competence questioned, or also just assuming a certain level of cultural competence based primarily on their racial background. Supervisors of color have also reported having their competence questioned by white supervisors. They've experienced racial microaggressions. And white supervisors have reported some discomfort when working with supervisors of color. And this is a critical piece. White supervisors have reported at times holding back from giving constructive feedback, not wanting to appear to be racially or culturally insensitive. And they've also reported feeling less authorized to address racial dynamics. So this is what the literature tells us about how racial difference might impact dynamics within supervision. So you can see, race is very present in cross-racial supervisory dyads. And these are some of the ways in which people have reported their racial experience. So let me go back to the illustration of my supervisee and myself as a supervisor. I shared with you some of the background, and also the fact that I observed my supervisee in a way that I saw her differently than how she was working with other clients. And so at some point, I think this must have been the second or third supervisory session, I decided to share with my supervisee the feedback. Okay, so at this point, the focus of our supervision had been facilitating the therapeutic alliance with the supervisee and the client, doing assessment around distress functionality, and also me sharing my experience and kind of observation of the client, of the supervisor. So let me share with you what I did. And I hate to disappoint some of you, but my intervention on some level was a relatively simple, but not simplistic. It was a simple intervention. The first thing I did was I shared with my supervisee what I was observing. Shared with her that it was striking to me that there had not been any discussion of the client's racial background, both with the client and with me in supervision. And that's when, the supervisor disclosed some of her concern. And also I observed with the client, with the supervisee, that I was experiencing her in a way that was distinctly different from how she was with other clients. So just to let you know, our clinic allows us to do live supervision. So we have a recording, a live stream of the psychotherapy sessions. And so we have access right there to our supervisor's behavior. Oh. I lost a slide along the way. I'm not sure what happened to my slide. But my simple intervention with my supervisee was to initially validate the kind of perception and concern that she had. Clearly, my role as both an assistant professor in the program, as her supervisor, brought up issues of power. The fact that she was being evaluated both by a supervisor who was part of the core faculty brought up some concern for her, and the fact that she was working in a cross-racial dynamic and was working with a Black supervisor. And the concerns that brought up for her, I wanted to validate and acknowledge. So I think the fact that I wasn't kind of that I was open to some of those concerns, and I responded in a validating rather than punitive fashion was helpful. And then the other intervention I offered to her was I encouraged her to have a discussion about racial difference with her client. And part of the way I did that was to engage my supervisee in a discussion about racial difference in our process. So what it meant for me as a Black male supervisor to be working with her, how our racial difference was constructing the space, possibilities, and then encouraged her to take some of that discussion to her client. And the final thing I did was, while recognizing her fear, also emphasize to her that she actually did and was in possession of a skill set that allowed her to engage this discussion with her client. And the way I did this was indicating to her that she did possess counseling micro skills. She knew how to ask open-ended questions. She knew how to phrase direct or indirect responses. She knew how to provide a reflective statement. These are all things that she was able to do and did do it consistently. And so I encouraged her just to take what she already possessed and apply it to the area of race. Okay. So this is striking for me in my work as a supervisor and as an instructor. As you know, as mental health professionals, we will ask of our patients and our clients very intrusive, very invasive questions. Questions of trauma background, sexual trauma, physical trauma, emotional abuse, questions of family dynamics, which often elicits pain for our clients. Yet when I have asked supervisees and students to inquire as to someone's racial identity or their racial background, usually the response I get, or often the response I get is, oh, I'm not sure if I can do that. It feels a little uncomfortable. And then I have to remind my supervisors and students that in the process of an intake, they have asked very invasive questions. And what I'm asking them to do is actually ask a question that is most likely a little less invasive. And then process kind of what is the fear or the concern that gets in the way of them doing that work. Okay. So again, that might sound like a simple invitation. A simple intervention, an invitation for your supervisee to actually engage and address racial dynamics. But I think to be attentive to the concern or the fear associated with that addressing is important. And also to remind your supervisee that most likely they actually have a skill set that allows them to do this. So I want to shift. I've got about 15 more minutes of commentary left, and then we can open up for questions. I want to take a few minutes to focus a little more specifically on racial trauma. Okay. And I'm going to go back to my poll. I've got 2 questions on trauma and racial trauma in supervision. And so let's take a few seconds or a minute or so to do the next question on our poll. Okay, so this is a question on, on comfort level of providing supervision for clinical cases where the primary clinical presentation involves trauma. Okay, so I feel comfortable providing supervision for clinical cases where the primary clinical presentation involves trauma, and there are your options. So why don't you go ahead and respond to the poll. Okay, we're creeping up to our 70% response rate. Let's see if we can get there. Okay. Thanks for engaging. So here we have, by far, the majority of you are feeling comfortable providing supervision where the primary focus is trauma. So 63% of you agree. 6% of you strongly agree. So by far, the overwhelming majority of you are feeling comfortable addressing trauma in clinical supervision. Let's get to the next question, which of course will not surprise you. This is a question on racial trauma. Okay. So the exact same question, but I've added racial trauma. So I feel comfortable providing supervision for clinical cases where the primary clinical presentation involves racial trauma. So why don't we engage the poll here? And we'll wait to get to our 70% cutoff. Oh, that's an arbitrary cutoff that I'm imposing. Okay. Okay. So thank you again for engaging. So it looks to me that here the results are significantly different. Again, I'm not using that in a statistical context. These are significantly different. So we have 25%, so about 45% of you are feeling comfortable, which I think is different to the 70% who felt comfortable with trauma in general. And perhaps 25, 55, 56% are feeling not sure or disagree with the idea of being able to provide supervision where the primary focus is racial trauma. Okay. So that's an important discrepancy. It's an important discrepancy. And perhaps some of the comments that I'm going to share with you will be helpful in that regard. I'll also share with you that if you are feeling a certain discomfort or uncertainty or lack of confidence, you are not alone. So this article published in the Journal of Multicultural Counseling and Development in 2018 surveyed a relatively small sample of counseling professionals. And the focus of the survey was getting a sense of how comfortable people were with treating race-based trauma in counseling and psychotherapy. And out of the sample, 70% of the participants reported working with clients who endorsed racially traumatic events, and 70% reported having received no clinical training for responding to racial trauma. Okay. So again, if there is some discomfort or uncertainty, possibly part of the discomfort and uncertainty is associated with a lack of clinical training when dealing with racial trauma. Okay. So I think of racial trauma in supervision in the context of harmful clinical supervision. A colleague of mine at UAlbany, Michael Ellis, has done a wonderful work in the area of harmful clinical supervision, both theoretical and empirical work. And the definition of harmful supervision they offer is supervision where harmful supervision is supervision that includes supervisory practices that result in psychological, emotional, or physical harm and trauma. Okay. So in the context of racial trauma, it's very rare that a supervisee would experience physical harm, but it's not that uncommon that there is possibly psychological or emotional harm, as referenced by some of the earlier disclosures. Okay. So when you think about racial trauma in the context of supervision, I think it's important to realize that based on a supervisee or a supervisor's experiences of race, racial trauma could provide a context for supervision, but it also could be a process in which racial trauma gets enacted within a supervision experience. Okay. So the work that has been done on racial trauma more recently comes out of this larger body of work that simply indicates that, you know, experiences of racism have adverse physical and mental health outcomes. That a well-established finding in the literature that's been supported by multiple meta-analytic studies at this point in time. And so within that larger kind of experience of psychological distress or psychological harm, we locate the narrower focus on racial trauma. And a definition that I'm using for racial trauma is simply the experience of sustaining an emotional or psychological injury in response to a direct or indirect racist event. And that definition builds on the work of my mentor and colleague, Robert Carter, you know, who has published a model on race-based traumatic stress. And within that model, he tends to encourage us to think of race-based trauma not necessarily as a psychopathology, but as a kind of emotional response to racist experiences. And clearly, an appreciation of racial trauma also needs to appreciate the kind of cumulative, generational aspect of racial trauma within the United States, based on the history of how people of color, indigenous folk have been treated within this country. I'm looking at my clock because I have a couple of stories to share, but I don't think we're going to have time. Let me share one story with you. Okay. I mentioned to you that I have, actually, let me share two stories with you. Prior to my becoming a psychologist, I had a professional life as a registered nurse in the area of oncology. And a lot of my work took place just before I switched over to psychology. I had worked at Sloan Kettering Cancer Center for a number of years. And the reason I'm sharing this story with you is that I want you to think about how racial dynamics play out in these day-to-day interactions we have with patients, we have with clients. So the story I'm sharing with you is of a young Black male, I believe 32, with a diagnosis of AML, who was being treated at Sloan for a bone marrow transplant. So this is back many years ago when I first started working at Sloan Kettering. I was assigned, he's assigned as his primary nurse. And I remember, even now, as I'm telling you this, I remember this very clearly. He was in the preparation phase, so had been exposed to, you know, high-dose chemotherapy, high-dose radiation, and subsequently developed significant mucositis, which was being treated with morphine, continuous morphine infusion, which was impacting his kind of his mental status. The morning of the incident I'm sharing with you, he had just been seen by the medical group, so the attending nurse practitioner and hematology fellows in the morning rounds. And shortly after he was seen by them, I was part of that group attending to him. He buzzed and called for me to come in. Went in to see what he needed. And he motioned to me to come a little bit closer. So I came a little closer, leaned into him. And he said to me, almost in a whisper, he said, and I apologize for the language, this is his language, not mine. He said to me, I'm so glad that you were here. I thought the crackers were coming for me. Okay. So what struck me about that interaction is, where did this 32-year-old Black man from Brooklyn, New York, in his kind of morphine-induced confusion, what made him go to that point of fear, being surrounded by white professionals? And I understand that partly in the context of generational trauma. So when you think of racial trauma or racial trauma reaction, I'm not going to share the other story with you to be respectful of our time. When you think of racial trauma or racial trauma reaction, what I want you to think of is what gets activated in the person who is experiencing a trauma reaction. And some of this clearly is familiar to you because we understand this as being part of trauma reactions in general, the sense of an emotional or physiological activation. This young man felt scared. Okay? A sense of being hypervigilant, scanning to assess for safety, trying to avoid a perceived threat. This young man took some comfort in seeing me, another Black person, as part of that group. And then often, in our more recent work around racial trauma, we are finding that participants often report a sense of anger and a sense of being demoralized. Okay? So if you are working with a supervisee of color and you sense a cautiousness, perhaps some withholding, again, you have reason to inquire around the experience of race. Okay? So how might racial trauma play out within a supervisory experience? Okay. Here are some areas that I'm sharing with you. Racial trauma can play out if a supervisee's experience of race is devalued. Okay. So there's a lack of appreciation for a supervisee's of color's experience within a social or historical context. It can play out if there's just a minimization or avoidance, just either downplaying or just ignoring aspects of racial difference, okay, or attributing emotional reactions that could be associated with race, attributing it to the person's personality. It could be, racial trauma could play out if there is this, just what I call practicing of whiteness, that is engaging negative racial stereotypes, performing microaggressions, etc., which we have already heard about, or viewing cultural difference as deficient. Okay. It can play out if there is an imposition of whiteness. Okay. And I've seen this play out in a supervisory context in ways that are unfortunate, okay, where supervisees of color or international students, I'm thinking of Asian students that I've worked with, where they have been encouraged to kind of adopt an assimilation, to take on aspects of white culture, ostensibly as a way of facilitating, their training, but really in some way that could be as an imposition of whiteness. Okay? There also could be racial trauma where the experience of racial discrimination is delegitimized. So a supervisor might report to you that they are experiencing racism within their clinical setting, or experiencing racism from a client, and the response is one to question. Perhaps you misunderstood what was said. I'm sure your client didn't mean it in that way, etc. So a real delegitimizing. Okay. And then perhaps the most critical way in which racial trauma could be enacted is the failure to provide safety. Okay. So I believe as supervisors, we need to advocate for the safety of our supervisees. And if a supervisor reports an experience of racism, again, to downplay it or dismiss it conveys a sense that the supervisory space is not safe. And then again, not attending to aspects of race, or putting the onus on the supervisee to bring up race. Okay. And so I have some examples here of ways in which supervisors can actually engage a discussion of race, which does not put the onus on the supervisee, especially a supervisee of color. So as a supervisor, you might want to say something as simple as, I wonder if we can talk about how both of our racial or cultural histories might impact our work together. Or as a supervisor, you might say, early on in the work, I'm going to be attentive to how my own racial cultural experience might impact or influence our work together. Yeah? So you are taking ownership as the supervisor for that discussion. Eklund has got a wonderful publication 2014 and provides some examples of questions that could facilitate discussions about race with your supervisee or with your client. What meaning do you attach to who you are racially? How do you define yourself racially? How does race facilitate or impede interactions, etc.? And I would add to what Eklund is offering here. I would say that these are questions that could be applied both to the supervisee and the supervisor, as you both seek to understand how racial difference might shape the space that you are working with. Okay, got about 5 minutes. So there's a wonderful qualitative dissertation that was conducted by Laura Dupaton. I don't believe that the dissertation has been published as yet as a peer-reviewed manuscript, but I would encourage you to access this dissertation. The quotations that she shares from her participants who were Black female therapists undergoing supervision are really quite powerful and quite profound. I'm just going to share one or two with you. Here you have a supervisee talking about the fact that they had built up experiences with racism, prior to engaging the supervision space, and said, I don't trust my supervisor because she didn't allow the space to be vulnerable or open up about what was happening. I got reprimanded. It was just like in the sessions, not having a voice with these white families and then coming back to a predominantly white workspace where I don't have a voice there either. It's like I tried to have a voice and I got shut down. Okay. I think that's an example of not attending to or not providing a sense of safety. Some of Dupaton's participants spoke about courage. As a supervisor, you can be afraid when someone comes in to share their experiences with you. In this case, the participant supervisor couldn't handle when I came in and said, I feel broken because I'm going to these houses and these people don't like Black people and it hurts. And she couldn't handle that. So it never got talked about. And what supervisees want from their supervisors. In the context of race, but I think more generally as well, feeling that the supervisor is being their authentic self is a big deal. Some of the supervisors are rich in content and they are very smart and they have ways of looking at things or narratives that have helped me to look at things. But I really need a supervisor that has heart. So here you have a supervisor craving a sense of authenticity from her supervisor. So what do supervisors do? Okay. First of all, I think supervisors kind of reflect on some of the material I've just shared with you. And then Pietrse essentially says supervisors need to step up. I argue that firstly, the supervisor needs to work to create a context within the supervisory relationship in which conversations about race and racism might take place. Okay, so Pietrse reminds us that as supervisors, it's our responsibility to create that context. And again, just as I share with my students and supervisors, as supervisors, we can do this. We can invite, we can engage, we can bring our own experience into the supervision space. As a supervisor, critically important to acknowledge our own social location. Okay? Acknowledge the identities that we embody that might be privileged and might inform how we engage with our supervisees. Okay. When working with a supervisee of color, really critical to acknowledge, engage your supervisee as a racial cultural being. How important is your racial identity to you? How has race shaped your life experience? And also important not to view your supervisee as a representative of a racial group. Okay. So understand how your supervisee experiences their racial identity. Critically important to prioritize the relational aspect of the supervisory process. So going back to some of the earlier findings that I shared with you. Prioritizing the relational aspect will really facilitate that sense of safety. Earlier, we had some discussion about the utility or the necessity of humility. And we're going to have a session immediately following this on the notion of cultural humility. So I think about supervisors practicing courageous humility, pushing through your fear, pushing through your discomfort, and attending to racial difference, acknowledging your discomfort, inviting a dialogue, and enacting humility. And then checking your privilege, identifying it, making choices that go against privilege, challenging whiteness as normative. Some more material from Eklund, which you can read through at your own leisure. My final comment would be that perhaps the most profound way of attending to racial trauma is engaging anti-racism as a day-to-day practice. Mill and Garan offer this web of resistance in response to the web of institutional racism. And I would point you to this wonderful article published last year, Liga and Miranda, adopting an anti-racist approach in psychiatric care. And in this article, they indicate people who are racist, and this is drawing on the work of Kendi, people who are racist when endorsing or supporting racist ideas and policies. Conversely, people are anti-racist when endorsing ideas and policies that promote racial equity. Everyone, every day, through action or inaction, speech or silence, is choosing in each moment to be racist or anti-racist. And so what I will leave with you is, if you want to effectively attend to racial difference, prevent racial trauma, I would ask you to pose this question to yourself every time you engage supervision. What will I do? How will I be in the supervision hour or in the supervisory space that will convey to my supervisee that I am committed to anti-racist practice? So I'm going to stop. I have gone 10 minutes over what I intended to go. I apologize. And I just want to open up for some feedback, observations, questions, or comments. And again, I really appreciate the opportunity to spend time with you discussing, these critically important topics. So I'm going to stop sharing my slide. I'll leave with sharing a statement from Angela Davis, and then invite some commentary, questions, observations as we conclude. So.
Thank you. First, just a comment about thank you for that. Really appreciated that talk. And yeah, I have some things, but I'll let other people make some questions and comments before I comment. Anybody else?
Thanks so much. And I apologize for my
No worries. Also, we have time in between break built in, so we can continue. If people have questions, we can continue. Our next speaker doesn't start until 4 o'clock.
Okay, great.
Does anyone have any questions or comments they would like to make? I mean, while we wait, I will take the opportunity then to comment. I just think that a few points that are really so important to the work that I do with the trainees is just, if you could just reiterate for the group the skills that your trainee already had, that she possessed, that she was doing with other clients, that you encouraged her, your intervention was to encourage her to apply those skills that she already possessed, that you already witnessed her demonstrating with other clients to race. Can you just reiterate those specific skills that she already had?
So by the time we are working with clients, or I mean with supervisees, we assume that they've gone through some introductory training around doing therapy, and some of the training involves the acquisition of counseling micro skills. And so the counseling micro skills are, using an open-ended question, providing a reflective statement. It sounds like you are, using direct questioning, indirect questioning, understanding or noticing nonverbal communication. And so when my supervisors or my students say, I don't know how, I respond by saying, actually, I think you do. You do know what an open-ended question is. I've heard you use open-ended questions. So just apply that skill set to this area of race. And that allows us to kind of explore, okay, so what's blocking? What's getting in the way? And often it's discomfort or fear. And sometimes for white clinicians, I think it's the fear of kind of, I've heard people say this to me, it's the fear of betraying my racism. You know, so that was really helpful to Dr. Ackerman-Berger's discussion about microaggressions and how we all, you know, if we're in a racist society, we're going to take on some of these racist notions. And so we want to work towards dispelling them. And so that's the piece, by really highlighting that actually you do have access. And I would say the same applies to supervisors who are hesitant or reticent. You know, I would remind, actually you do have access. You can do some facilitation around this area.
I completely agree. And I just wanted to highlight those because I often make the same intervention, oftentimes even to supervisors or other faculty who are uncomfortable and feel that they need to be an expert in race and racial theory, or, you know, in order to go there with a patient or a group, you know, even. And we do this all the time. We're not an expert on everything that our patient comes into the room with, and yet we are able to provide good care. And so we need to use those skills. So I just really wanted to echo that.
And again, you know, I don't mean to simplify, because clearly there are other bodies of knowledge that's important to access. But I'm talking about that in the moment ability to engage and facilitate the dialogue. Yeah. Any other questions or observations, or if people want to put something in the chat?
I mean, the other comment I will make is that I did also really enjoy your notes to supervisors about making it so it's a little bit more equal, that they're encouraging their patient to talk about race. Maybe they're going to bring up race. The supervisor will bring up race, but also that they're going to, as a supervisor, talk about their own racial background, or be a racial being. You know, oftentimes as a trainee of color, with supervisors who are not of color, some of them did want to ask me about my interaction and how they thought race played a role, but they would never talk about their own racial dynamics. So I really just felt more on the spot than anything else. And it didn't feel like a helpful kind of supervision for me.
You know, I think, so part of what I am inviting supervisors to do is to engage self-disclosure around their own process. And again, I don't want to be naive. Clearly, supervision takes place in a kind of power imbalance dynamic. Yet at the same time, I think effective supervision requires vulnerability on the part of the supervisor as much as it does on the part of the supervisee. So clearly, I would encourage supervisors to bring that aspect of their lived experience to the process as well.
Yeah, I just wanted to say I thought this was a fantastic talk, and I really appreciate how you're encouraging us to really take a look at ourselves and our life experience, our lived experience, and our quality of life, and also encouraging us to utilize anti-racist practices. Specifically, I'm interested in anti-Black racism, because we know that has served as a significant impediment to care for people of color, specifically Black and Indigenous people, who have been oppressed very differently here in this country. It's quite evident with our health inequities. So if we're aware of that and we have that lens, then maybe we as healers can figure out how to fine-tune ourselves or increase our toolbox so that we're able to help the people that we truly serve, people who are suffering. So thank you for that.
Thanks so much for that, Tyson. I think that's why it's so important to understand the history of our field, because I do think that these paradigms of inferiority are still at play.
Totally.
And unless we interrogate how that's at play in here and in here.
Yes, that's right.
Yes,
I totally agree. You're preaching to the choir. I think what makes it very difficult for me is how to get other people to be